Greens here. We're going to do a little bit more follow-up on the Susie Green Caroline Farrow row, again to address some of the misinformation that Ms. Farrow was putting out. Whether deliberately or through ignorance, I do not know. But looking over her published work on this subject, she certainly is very ignorant. So a number of points that she made. She said that the Thai authorities, to start with, had for some reason changed the minimum age for genital reconstruction surgery, sex change if you like, from 16 to 18. It's actually had nothing to do with Thailand. Thais have always followed the World Professional Association for Transgender Health, otherwise known as WPATH, guidelines on the treatment of trans individuals. And what happened was that after a number of high-profile cases, WPATH reviewed the evidence and took the very reasonable position that it didn't actually make much difference whether you have surgery at 16 or 18, provided that adequate hormonal treatment was in place, because you can effectively block the testosterone that is causing the damage to someone who is male, who wishes to appear to be female. So they said, right, let's just change it to 18, and Thailand followed suit. This was not about, and I quote, panic on Thai authorities' part. It was just that they have always followed these guidelines. My goodness gracious me. Jackie Green had what is called rectosigmoid vaginoplasty. Now, to explain what that is, let's just remind ourselves what happens in the more conventional genital reconstruction surgery in a vaginoplasty. What happens is that essentially the penis is split apart, inverted. The glans is used to replace or to replicate the female clitoris. The skin of the shaft of the penis and also that of the scrotum is used to form a tube, which is put inside a cavity which the surgeon creates within the lower abdomen. Now, in some individuals, there's just not enough skin, and one reason can be that, as is the case in Green's case, that they had begun testosterone blockers quite early, so they didn't actually have full penile development, and they didn't have full scrotal development either. Other causes can be in patients who are older. They can have a situation where they have, for example, an orchidectomy or orchiectomy, which is where they have their testicles removed, and then a few years later go to the full GRS. Well, if you're going to do that, what you should do, and your surgeon should offer this, is have a pair of silicone replica testicles put in place of the real ones that are being taken out, and that will maintain the size of your scrotal sac so that the skin is there for use later. Where this is not available, one other possibility is to use a small part, a length of the lower bowel, which is called the sigmoid colon. Now, what you do here is you basically use a surgery that's not that dissimilar to one that's used in treating bowel cancer. You simply take out a part of the tube and reseal it, because there's plenty of length, it's not a problem, and use that as a part of the vaginal canal that you're going to construct. Now, this is a well developed technique. It was originally developed to treat natal women, real women, who had complications in hysterectomy, such that they lost part of their vagina, and this was a way to restore the depth that they would have so they could have a normal sex life. It's completely safe, it's completely routine, in fact, and just to make a point which some people don't understand, it doesn't smell. The internal of your bottom does not smell, right? If you've got a smelly one, that means you have a problem and you need to see a doctor. Either you are not able to clean yourself properly, which is the case with some people, or you may have something like yeast infection, you may have some other problem which is actually more serious, and so if you do have persistence in that area, that it's always a bit ooey, then you do need to see a doctor. Normally it doesn't smell at all. It smells and tastes of absolutely nothing. The material that is actually makes up the lower bowel is called squamous epithelium. It's the same as all the other skin in your body. It's basically a mucous membrane made of squamous epithelium, which is backed by a layer of of smooth muscle. It's involuntary muscle. It's called smooth muscle. You can't you can't force it to do anything. It all acts completely reflexively. So that can be used, but it doesn't smell. It's exactly the same as the material on the inside of your mouth. Quite honestly, there's no difference. And if your mouth smells that bad, you've got a problem. So don't worry about that. Now, the next thing to go on to is that I've also got information here to say that Jazz Jennings, when she had her surgery, she had a new technique which used subdermal peritoneal tissue. Again, this isn't surface skin, this is skin from underneath the skin that you see from the peritoneum, which is the inner wall of the abdominal cavity, and other skin grafts apparently. We don't know what the long-term results of these are because that's actually a very new technique. The older one, the rectosigmoid technique, it's well understood. And there have been many of these done, and basically no problem. Now, in the cases of Jazz Jennings and Jackie Green, these were caused because they did start testosterone blocking techniques at a very early age, and they didn't actually grow their male parts big enough to provide enough material to use for a regular GRS. In most adult Caucasian males, right, because penis size is different on each ethnicity, sorry about that, it just is, surgeons claim that they will have no difficulty producing a vagina of a depth of 6 to 7 inches, which is well enough to accommodate most penises, just using the skin available from the patient's penis and scrotum. So normally the advanced techniques aren't usually used just because they're an added layer of complication. Surgeons will use them if they have to. Now, Caroline Farrow also made another huge whopper, again, whether a deliberate lie or just out of ignorance, I don't know, when she said that those people who have GRS will have to go back every 10 years for a checkup. That's a complete piece of nonsense. That's just not true. Now, after a GRS, most surgeons require a follow-up visit just to make sure everything's fine. They're looking to make sure that there's no excessive scarring inside the neovagina, that the neovagina isn't too slack. That can be a problem. I've certainly heard of that one. If it is, they'll just tighten it up. That there's not hairs which have been turned inside the vagina and causing irritation and perhaps bad odours. You don't want that. Most surgeons will require you to have full electrolysis prior to surgery, but sometimes one slips through. In an adult, no, there's no requirement for follow-up visits after those early ones. What will happen is that you'll be required to use a thing called a stent, which is like a dildo, and that is used to dilate the neovagina till everything basically heals in place and there's no chance of it collapsing. That can take from 6 months to a year depending on the individual, but once it's all in place and it's all operational, there's no problems. Now, we have trans women today who were operated on by Dr. Bourreau in Casablanca in the 1950s and 60s, still alive, still living as women, and no problems at all. And we're talking 60 years later. These are elderly women now. They've never had any issues with their neovaginas. So this, oh, you have to keep going back to the surgeon, it's a load of old nonsense. I think, I've done a bit of research on this over the last week, I think it comes from cases where, similar to the David Reamer's case that I had discussed last week, where an infant has been damaged, and so a neovagina has been reconstructed to try and repair this damage. Well, that's an infant. I mean, they're still growing, so it's obvious that you're going to have to keep going, revisiting the scene and modifying the vagina, because it's not going to grow in the same way as the rest of the body does. It's not a natural vagina. But in an adult, this is not necessary, right? 60, and this is one of the reasons probably why WPATH changed its rules, because they went, well, 18, they're definitely going to be big enough that there's just not going to be long-term problems. Okay, now the next thing that Farrow went on to spread untruth about was the risks of genital reconstruction surgery. Now, I've done a lot of searching, and I can find no no confirmed fatalities in surgery while undergoing SRS since 1960. Now, maybe I'm looking at the wrong place, but you know, knowing the political hot potato that it is, if there were really an elevated risk of serious complications in surgery, then it would be made public. And you know, go online yourselves. You will not be able to find them. It's true that in the very early Lily Elba, for example, who a very early trans woman pre-war, she did die after her surgery, but that was because they tried to transplant a womb from a dead woman into her body so that she could, they thought, be actually reproductive. Now that happened because they didn't understand the way that the body rejects or accepts transplanted organs in those days, and she died because her body rejected the implanted womb. It wasn't because of anything to do with the actual SRS, the neo-vagina construction, at all. I have come across at least one case where a female to male transitioner died in surgery, but again, it seems rather uncommon, to be honest. Although genital reconstruction surgery, sex change if you like, is serious, it's a serious major surgery which requires a lengthy recuperative period. It's irreversible and it's a major decision. It's not actually that invasive a surgery. If you think of things like open heart surgery, lung surgeries, many of the other surgeries that are today actually quite routine, this is nothing like the same level of complication. There is a great deal of care has to be taken preserving the functional neurology of the neo-vagina, but it's not actually that serious an operation. It's restricted in its area to this very small area in the around the genitalia, and basically it is not an elevated risk procedure at all. Another thing to look at, which Mauro touched on, was the use of hormones. Now I'll put up a link here. There's an excellent paper there, on an excellent piece on there about the risks of feminizing hormones over the long term, written by Amanda, and the fact is that they're very, very few. Essentially, a person on feminizing, a male on feminizing hormones, has roughly the same risk of female typical diseases as a female. There's a tiny elevation in some risks, but it's really, really small. And similarly, females to masculine, they have an elevated risk of male typical diseases. So that means is that males taking estrogen will be a slightly higher risk of things like estrogen cancers, breast cancer for example. Females going to masculine will be at slightly elevated risk of heart disease, but not significantly more than natal females or males respectively. Okay, so that's something you shouldn't really have to worry about. In general, GRS, genital reconstruction surgery, is a relatively safe procedure in males. In female to masculine, it's much, much bigger. It's a much bigger job altogether. Consider what is actually involved. In a male, what will be involved is that essentially the penis will be inverted and used to form a neo-vagina. Most surgeons will remove both testes, although some apparently leave one in, because this basically protects against osteoporosis in the long term, and also maintains a high level of libido. For a female going to male, it's much, much more complicated. Major skin grafts will be required, a lot of scarring, very long recuperative period, and to be honest with you, well, if you've ever seen the results, okay, that's all I'm going to say. Another issue that is often brought up with GRS is, do the patients orgasm? And the answer is yes. Yes, they do. I have certainly spoken to enough post-operative male to female feminine transsexuals to know that yes, they do orgasm. Now, it can take some time for this to become easy for them. In the course of the operation itself, a fair amount of what's called tissue edema builds up. That's basically just fluid that causes swelling in the operated areas, and it can take quite a long time to completely go away. That's why, by the way, when people have operations, they have drains fitted. That's to try and get rid of as much edema as possible, as early as possible, because of the discomfort it causes. It can take weeks or perhaps months for the area to settle down enough such that stimulation will produce an orgasm. Do they lubricate? Well, that one's a complicated one. The prostate is what produces most of the lubrication in the male penis. Now, surgeons leave the prostate in. They don't take that out, which is highly sensitive and will cause orgasm by manipulation, as I think most gay men know. So those are left intact, and those are responsive to stimulation, to massage, and to therefore lead to orgasm. The prostate produces 90% of the fluid in a male emission, so that's still there. That potential, rather, is still there. What you have to understand is that feminizing hormones will reduce the output from the prostate significantly. I know pre-op trans women who simply don't ejaculate at all. There's no emission. They're completely dry. And that's because they've been taking feminizing hormones for so long that basically their prostate just doesn't do it anymore. If they come off the hormones, then they start to rebuild up. It's not a permanent thing. So, but that will cause, that may cause a certain dryness. Because the prostate is also not only responsible for the emission, most of the white fluid is from the prostate, but it's also responsible for what people call pre-cum, which normally in an uncircumcised man will help lubricate the head of the penis. Well, that lubrication can also be used to help lubricate the vagina, but again, because of the feminizing hormones, that tends to dry up. Not always. A person on regular maintenance hormones, feminizing hormones, they produce very little ejaculate, and so there tends to be the dryness. So usually women like this are going to have to use some sort of lubricant, and there's plenty of them on the market. KY jelly is the one that's usually recommended, but there are plenty. All GRS, doesn't matter which sex you are to start with, is a very serious decision, right? It's going to permanently change your body. Yes, I do know that there have been cases where people have had vaginoplasties and then have changed their mind and they've had penis reinstalled. This is just not going to be successful. I'm sorry, it doesn't work. You really need to know what you're doing. And I'm going to do another video and record it in a few minutes about the people I think should and the people I think should not have GRS. But certainly if there is any doubt in your mind, right, don't have GRS. Just use hormones. There's loads and loads and loads of trans women out there. They're intact. They still have their penises, and they're completely passable. If they're HSTS, they will be completely passable. They live completely as women, and it's just not a big deal for them. Certainly here in the Philippines, most girls would absolutely go for a nice set of silicone boobs before they'd even think about GRS. It's like, they're not bothered about it. They can have sex in a way that pleases them without that. Now, for some individuals, anal sex, which is what they have to do, is just too painful. And that's to do with relaxation, That's a whole different subject, but it's just a fact that some people can't actually take pleasure in being penetrated anally because it hurts them too much. And of course, you get hurt once, it's going to be worse the next time. So for people like that, then GRS is a way that they can have sex in a normal manner without being afraid of it. And secondly, an HSTS basically doesn't use her penis. It's a piece of jewellery for her. It's redundant. She hardly ever touches it. So, replacing it with, that's basically a sexual organ that she does not use. So replacing it with one that she would use seems logical. It seems like a reasonable approach. Certainly, given that we have had significant numbers of GRS being carried out, really since the middle of the 1950s, it's like 65, 70 years now. We've had an awful lot of people have had these surgeries. And the success rate with GRS is very high. The reported satisfaction rate is extremely high, sometimes as high as 90%. And basically in a cosmetic surgery, that's unheard of. You know, that's right at the top end of the scale. So as long as individuals are really certain that this is the life path they want to follow, then they should follow it. Having said that, that level of certainty requires a certain degree of maturity. I am not by any means arguing for transing children or GRS being carried out under the age of 18. I think this is all fine. These are sensible rules. Don't do it. Between the ages of, say, 12 to 18, the effect of testosterone in male to feminine can be easily managed using testosterone blockers with no long-term effects. I'm sorry, some people say, oh, long-term effects, there aren't any. Certainly there are people who are pre-op who've never had GRS, who retain their testicles, and they've been on blockers for decades now, and they've never had any problems from it. So you have to be aware that there is a fair amount of misinformation coming from the likes of Caroline Farrow about the risks and potential harm that GRS can cause. My view is that as long as you're talking about someone of suitable age, who's mentally competent, and who is a suitable candidate for GRS, and I'm going to do another video about that, then no, it's a serious operation, but it's not problematic. You know, if that's what you really need to do, then you should do it. From my correspondent here, I have certainly had similar comments from other people. She says all GRS are major surgeries, shouldn't be carried out frivolously or without proper consideration. Obviously, it's a very painful operation to undergo. I mean, this is an area of significant nervous density. You know, there's a lot of nerves in this area. You're going to start mucking about with it. It's going to hurt, and it's going to hurt for a long time. Especially as long as you have this problem of tissue edema. You know, it takes a long time for the swelling to actually go right down, and as long as there is swelling, it's irritating your nerves. So that's what we thought. There's Amanda here, my correspondent, says, you just had a surgeon cut out your testicles, peel your penis like a banana, and cut most of it away, cut a 7-inch deep hole in your perineum, where one didn't exist before, and then pop what's left of your genitalia inside out like a sock puppet. It's going to hurt. It is going to hurt. You're going to have to think about that. It's going to take a while for you to be better again. Be serious. Don't take these operations lightly. It's a very serious decision. It's not. The surgery itself is not particularly dangerous. It's certainly not an elevated risk surgery, but it's a serious decision. You're going to be off your feet for a fair while, you know. And then she says, post-operatively is a bit of a shit show for about the first 6 months, because you have the dilations to go through. Basically what happens is you'll be given what are called stents. They're basically dildos. They come in a range of sizes, and you'll be expected to use them sequentially till the biggest one. I remember a fascinating interview with Kevin Ballot, who is a post-operative Filipina trans woman, very beautiful, very, very beautiful woman indeed. And she was talking about her operation, and she said she'd been given 5 stents of varying sizes. And she said, well, the first one is for when you've just had the operation, and the interviewer's obviously eyes like gobstoppers, you know. And she got up to the 4th one, and then she stopped, and the interviewer says, what about the 5th one? Kevin, what's that for? And Kevin Ballot looks him in the eye and says, the 5th one tells us that you have a foreign boyfriend. So that's basically how it works, you know. The stents are there to acclimatise the neo-vagina to what it's going to have to deal with in terms of actual sex. If you're not going to have sex with it, why bother? You know, there's no real point. Again, cosmetically, the results are indistinguishable from a natal vulva, and I have to say that I have certainly seen examples which confirm that. Most of the Thai surgeons have pictures on their sites which, you know, they're obviously anonymous, but they show examples of their work, and some of them really are remarkably good, remarkably. And I've certainly spoken to enough post-operative trans women to know that this is the cosmetic side of it is not an issue. Surgery, plastic surgery, is extremely good today, and this is something that is well sorted out. Some surgeons, it is true, certainly in the past, I don't know if they still do, tended to do the major surgery in the first operation and then tidy up the cosmetics in their follow-up visit. Others prefer to do it all in one go, so that there's less ongoing discomfort for the patient. You would just need to discuss with your doctor what was going on. While I'm on this subject, I should point out that there is a percentage of people in the population who have an issue called keloid scarring. Right. If you are of African origin, or somebody in your family is, my daughter keloids, for example, be very, very careful. There are techniques to avoid keloid scarring that the surgeons will be aware of, but if you do suffer from it, you must tell your surgeon. You must tell, because the potential for irritation is enormous. And look, this is a sexual organ. It's supposed to be for fun. If you can't have sex without hurting yourself, there's just no point in doing this. So keloid sufferers are kind of a class apart. Sorry about that, folks. I know it's a distressing and unpleasant condition to have. It tends to happen in people who have, ancestry of recent African origin, if you like. Just be aware of that one. If you have a tendency to keloid, tell your surgeon. Ask his opinion. Okay, I think I've done enough there. Basically, the naysayers, the gender crits and their mouthpieces like Caroline Farrow like to spread misinformation. Now, I think that a lot of misinformation the other way is spread by trans activists, and I'm trying to be neutral. But there is absolutely no point in telling lies, and that's unfortunately what they're doing. GRS is not a dangerous surgery. It doesn't require loads and loads of follow-ups. The hormonal treatments are not dangerous, and you can have a full, unrestricted sex life as a woman. We're talking about male to feminine here, as a woman after it. And these are just the facts. They're just the facts.